This is Dr. Bernstein with the February 24th, 2016 Teleseminar. Thanks for listening. A couple of business matters to discuss first. I repeat my request that you not send in lengthy questions because people don't have time to listen to lengthy questions, and they will be screened out. Second is, please do not ask me questions that do not pertain to diabetes. We had several questions in tonight's list that related to cancer and other diseases. My specialty is diabetes. I'm not an expert in every disease that you may encounter. One more thing is my usual warning that I'm going to make certain assumptions about the questioner of each question. I may assume he or she is a type 1 or a type 2, and I may be incorrect. I may make other assumptions that are incorrect. So my answers are only guesses. They're not real answers. The intention of this teleseminar is to give you general information to all of you. So I might be wrong on any individuals. Okay. Our special subject for today has to do with a new announcement with regard to HDL. There's been a study conducted in Europe that had a lot of publicity in the past couple of weeks to the effect that HDL is a U-shaped predictor of cardiac risk, that very high values and very low values are both hazardous. However, the authors point out as an aside that probably will not be covered in the newspapers and in the general publicity that this report is going to get, that there are certain causes of high HDL that could also be causes of mortality. For example, the people with high HDL on average are consuming much more alcohol than people with low HDL. We know that alcohol raises HDL. So if someone's drinking too much alcohol, that may affect his mortality adversely. People may be using a lot of niacin and develop high HDL. And niacin can, in large amounts, adversely affect mortality. Likewise for statins. So there may be a number of medications and other substances that people may be taking that raise their HDL and also raise their mortality. So we have this tentative report that high HDL can adversely affect mortality as well as low HDL. Basically, we now have an unknown. HDL is now an uncertain indicator, but in the range that the report gives for protection, which probably is under 100 and above 60, HDL supposedly gives cardiac protection. So it's confusing, and don't take current HDL reports as absolute indicators of risk. First question, I'm a 55-year type 1, age 70. Well, this person is really a survivor. I've had type 1 for 70 years. This person has survived 55 years, which is very unusual. My latest lab results show that I have microalbuminuria. That is, there's a small amount of protein in the urine. Any cause for alarm? It means that your kidneys have been damaged by high blood sugar. if to give you an idea of magnitude, if you have, let's say, 100 micrograms of microalbumin in a 24-hour urine, you have some damage to your kidneys. But I had 1,500 grams of protein in my 24-hour urine. 1,500 milligrams, which is 1,000 times, milligrams are 1,000 micrograms. So I had thousands of times more protein in my urine than this person has. And with normal blood sugars, I reversed the damage. So it could well be that this person, who now has a small amount of protein in her urine, could do something to reverse the situation and not have to develop diabetic kidney disease. So, but showing any microalbumin or protein in the urine is a sign that something should be done. That is, blood sugar should be stabilized and normal, should be lower. Next question. I believe that I may have diabetic gastroparesis, but nobody any closer than you seems to run RR interval tests for cardiac autonomic neuropathy. What more commonly available lab test would you recommend instead, even if it is more expensive? Well, yes, it's true. I don't know of any physician routinely doing RR studies. It's the best test for predicting gastroparesis. It's a measure of damage to the vagus nerve. The vagus nerve is responsible for slowing the heart when you exhale, and it's responsible for digestion and stomach emptying. So if you're not slowing the heart adequately when you exhale, we also know that your digestion has probably been affected. And we can put numbers on this with the RR interval study. The most common study recommended by the medical profession is the gamma ray camera or technetium scan, where they have you swallow some radioactive eggs or chopped liver, and they take gamma ray pictures of your gastrointestinal system, especially your stomach, over a period of hours and see how fast you digest the meal. The trouble is that the hallmark of gastroparesis is its unpredictability. You don't know when you're going to be emptying your stomach. Today you might empty it rapidly. Tomorrow you might take 12 hours to empty your stomach. So you go for a technetium scan and you go today, you'll show normal. But if you went tomorrow, it wouldn't be normal. I found after doing these on patients that we had to do 4 studies in order to get one abnormal on most patients. If you have extreme gastroparesis with nausea and vomiting, we might get it on the first study. Now, what alternates are there? Well, I get clues just by looking at blood sugars. If a patient is following the regimen of my book, Diabetes Solution, and would therefore otherwise have normal blood sugars around the clock, and on some nights they have dinner, blood sugar goes low after dinner, and then is very high the next morning, that tells me that they probably did not promptly digest their dinner. We're talking about type 1 diabetics now. Took insulin for the meal, intended to cover the dinner, but the dinner didn't get digested, and blood sugar went way down, had to take glucose to bring the sugar back up to normal, and then overnight the stomach emptied and the dinner finally raised the blood sugar, but there was no rapid-acting insulin left to cover it. So just by looking at blood sugars, you can draw likely conclusions about gastroparesis. And this is reiterated if you get variability. One night you get low, then high, and then the next night with the same meal, you get level after dinner and level overnight. That tells me that you emptied and it was covered by the rapid-acting insulin you took for the dinner. So things worked nicely that night, and then another night they go low, then high again. These are all clues to gastroparesis. And of course, there could be other digestive problems than gastroparesis. There are many that may exist, but in diabetics, the most common thing is gastroparesis. In fact, in my experience, virtually 100% of new type 1 patients whom I see after they've had diabetes for 5 years have gastroparesis, and we spot it on the RR study. In fact, I spot it on the RR study for type 2 diabetics too after 5 years. But because they're making their own insulin, they may not show the extreme blood sugar patterns. So the only alternate to an RR study that I can think of is looking at blood sugars. Next question. I'm being treated for low thyroid, low free T3, and low T4. You mentioned supplementing with selenium. What amount do you recommend, and should it have yeast in it? This is another one of those questions looking for magical answers instead of real answers to questions usually that relate to diabetes. Here it relates to thyroid disease. What I said at a prior teleseminar, or maybe in my book, is that the conversion of T4, the major thyroid hormone, to T3, the active thyroid hormone, is selenium dependent. So you have to have a normal level of selenium in your bloodstream. And most of the hypothyroid people whom I've tested have had normal levels of selenium. If your level is low, the amount to take for replacement should be determined by the doctor depending upon your blood level. So it's a matter of trial and error, adding small amounts until you get to around the middle of the normal range. You have to be careful with selenium because there's some evidence that high levels of selenium can make prostate cancer more aggressive. So we try to shoot for as far as the prostate goes, we try to shoot for blood values of around 140, but not higher. That seems to be protective for the prostate. But you don't automatically give selenium to people who are hypothyroid. You check the blood level. And in all likelihood, they'll probably need T3 replacement. Can diabetes lower or in any way influence or control mental functions or intelligence? My son is 20 years old now, but with diabetes since 5, not controlled at all. Well, if you've been listening to these teleseminars or looking at Dr. Bernstein's Diabetes University, we frequently mention the damage caused to the brain by elevated blood sugars. And it's especially present in growing children. Contrary to what many endocrinologists say, namely that the brain needs a lot of glucose to grow properly, the brain needs normal blood sugars to grow properly. And almost every month we see journal articles, scientific journals, showing studies where they look at the brain of growing children and see deficits caused by high blood sugars. So that's the story. I would still say that your son should start controlling his blood sugars. Get my book, Diabetes Solution. I would like to know how to best control my blood sugars during the week before and the week of my menstrual cycle. This is when I have most trouble keeping my blood sugars in range. Well, there are two things that I've tried that have been successful. Well, there's actually three. When the difference is in one direction, that is, let's say that starting a week before menses, your blood sugars go up, you could increase your basal insulin, and that might take care of the problem. But unfortunately, many women find that 1 month they'll go up and another month they'll go down, so that they don't have a predictive picture. If that's the case, one solution that works is to see a reproductive endocrinologist and get birth control pills to stop your periods, except for 1 month a year when you allow bleeding to occur. That 1 month you'll get unpredictable blood sugars, and all the rest of the year your blood sugars will be predictable. That certainly will work. Another option that has worked on some women but not on others, but I've seen it work on a number of women, is to give them long-acting metformin in the form of the good metformin, which is the brand name Glucophage. And we would give Glucophage XR, which is the timed-release version. And you'd either take it all the time, or you'd start it a week before you expect the blood sugar problems to occur. So if the blood sugar problems occur only during the week prior to the period, you'd start it 2 weeks prior to the period and take it all the way into the period. But again, if that's too complicated, you could take the metformin all the time. The dose would be by trial and error. You start off with a low dose, which is 500 milligrams, and if that takes care of it partially, you up it, and you could eventually go to 4 500 milligram pills per day. And I would probably be taking them on a rising and at bedtime, 2 in the morning and 2 at bedtime. You might let us know how this works. I've seen good results, but have not tried it on everyone. I am a non-diabetic double kidney transplant patient. My creatinine level is good, but total 24-hour urine is about 200 milligrams in 24 hours. Now, I don't know what that is, whether that's milligrams of protein or milligrams of creatinine. Would the low-carb, high-protein, and high-fat diet benefit the protein leak? Well, what benefits diabetic kidney disease, and this person is a non-diabetic, so now I don't know for sure that this person is non-diabetic, because many people who send us questions who say they are non-diabetic, it turns out have diabetes but don't realize it. So I don't know what the cause of the kidney disease was that resulted in the transplant. It could have been an injury. I just don't know. If the person is not diabetic, I doubt that a low-carb diet is going to make any difference. But certainly for diabetic kidney disease, you want to keep blood sugars normal. It's the high blood sugars that cause the diabetic kidney disease. In this case, I doubt that cutting carbo and raising protein and fat is going to make any difference. Next question. Diagnosed as type 1 in 1950. Well, here's another survivor. This man became diabetic 4 years after I became diabetic. For the past 2 years, I've been having cramps in my legs and feet. I have followed your diet since 2007. What could be causing the cramps, and how do I stop it? Well, for the first question is, are they really cramps? Cramps is this tight muscle that becomes very severely painful. There's diabetic neuropathy, which many uncontrolled diabetics get, that involves pains in the feet and legs that are not muscle cramps, but are neurologic or nerve pain. So we have to make sure that you're talking about muscle cramps. Now, if you have muscle cramps, the most common causes would be, first of all, the use of statin drugs. So if you're taking a statin, it could be caused by the statin. The next most common cause would be hypothyroidism. If you have untreated low free T3, you could get muscle cramps. Another cause is low serum magnesium. And your red blood cell magnesium level can be checked, and if it's low, you can your doctor can treat it with magnesium taurate or one of the other magnesium formulas until up to the point of getting the blood level back to mid-normal. Now, low serum calcium might be involved, and for some people, I would think rarely, but I remember my chief, who was the world's authority on the diabetic foot. He was not diabetic, and he lived to be about 90 years old. His name was Heinz Lippmann, and he used to get cramps in his hands starting when he was in his 70s. And he had in his pocket calcium carbonate pills, which is like Tums. And he would chew a calcium pill, and in a half an hour or so, his cramp would go away. Now, he insisted that it was because of the calcium pill, and he says that they worked. That's the only time I saw an example of using calcium to treat muscle cramps, and I didn't read about using calcium in any of the scientific journals, but he showed me many times a year. I would see him every week in clinic, and we'd go out to lunch, and he'd sometime during the day have a cramp. He'd take the calcium, and it would get better. So that's another possibility. I am a very thin 67-year-old woman. I've been diagnosed as pre-diabetic. Recent free T3 test is normal. Now that right away brings up a question, because I've had many new patients come in with a free T3 test done by their local endocrinologist. They're told that it's normal, and you look at the value, and it's in the normal range, but it's near the bottom of the normal range. And the normal range is just much too wide. What they publish in the on the lab report forms as the normal range is too wide. It's just like the range they publish for blood sugars, which might be something like 60 to 120, where normal is around 80. So we don't know for sure that this lady's free T3 is really normal. I am having a hard time gaining weight. I have added a lot of protein to my diet. My fasting and random blood sugars are 90 to 105, and after eating, my blood sugars spike 30 to 40 points. Am I developing type 1, type 1.5, or type 2 diabetes? Well, if this lady is already on a low carbohydrate diet, she should not have significant blood sugar changes if she's non-diabetic. But with these changes, she might be a mild type 2. I don't see her being a type 1, and I don't know what the definition of 1.5 is. That's a mythical definition. So I would think that if she's already on a low carbohydrate diet of the nature that we describe in our book, because there are many different low carbohydrate diets out there, and some low carb diets are very high in carb. In any event, I would think that if she's on a low carbohydrate diet, she might have very mild type 2 diabetes, which should be easy to treat. I am currently on Lantus Solostar insulin. That's a long-acting, very concentrated version of Lantus insulin. It probably has the same problems with increased affinity for IGF-1 receptors that might enhance the development of cancer that ordinary Lantus has. And it's made 300 milligrams per deciliter, 300 units per cc concentration, 3 times normal concentration, to jibe with the Professional Diabetes Association's recommendation of high carbohydrate diets, where you give them a lot of carbohydrate, you give them a lot of insulin, but you don't want them to take big injections for these massive doses of insulin, so you triple the concentration. That's what Lantus Solostar does. Now, what's the question? How could I respectively convince my endocrinologist to change my insulin to Levemir? Any advice would be greatly appreciated. And this is a lady from the United Kingdom. Well, first I would suggest that you go to the search engine on your computer, Google or whatever, and search for Lantus plus cancer. And you'll find many articles, probably, about studies of the incidence of cancer in Lantus users. Or you can go to the internet site of the journal Diabetologia, Diabetologia. This is probably the best diabetes scientific journal being published. It's published by the European Association for the Study of Diabetes, and they have a number of articles about the studies of Lantus and cancer, including the original article pointing out the very high affinity of Lantus for IGF-1 receptors. So you could pluck some articles from Diabetologia. If you get them through a medical school library, you can get them for free. If you get them through a university library, you can probably get them for free. If you're going to search Diabetologia on your own, you might have to pay for the articles. You could probably print out the abstract that they will display for free. When I do anaerobic exercise, my blood glucose stays relatively steady. Now, I have had many people talk to me about anaerobic exercise when they're really talking to me about aerobic exercise. Anaerobic exercise is so intense that your muscles get so rapidly tired out that they won't work. So within maybe a minute or two of anaerobic exercise, the muscle you're exercising stops working. And most people who tell me they're doing anaerobic exercise are not exercising like that. So it's always a big question. So this person says blood sugar stays steady, dropping or rising only 2 millimoles per liter, which is, 0.2 of a millimole, which is about 2 milligrams per deciliter, hardly any change at all. Now, when I do cardio, my blood sugar drops very suddenly and stays low for hours. I eat 30 grams of carbohydrate a day. I follow your book to the letter. Am I doing anything wrong? What could be causing this? Well, causing which? The steady blood sugar or the drop? Number one, when I go to the gym, I do real anaerobic exercise, and my blood sugar drops around 5 milligrams per deciliter per exercise. Depends upon the size of the muscle group that I'm exercising. If I'm exercising a big muscle, it drops more than if I exercise my hands, for example. But I exercise until I can't move that muscle anymore. When I do aerobic exercise, which I call cardio exercise, I try to exercise at above my theoretical maximum heart rate. This is very uncomfortable. It's very extreme, and it's approaching anaerobic. I'm not in pain, but I'm unable to talk to somebody while I'm doing this, and it's unpleasant. I don't like it. And there I will drop a lot, and I'll keep dropping for the next 6 hours. Now, what do? I take liquid glucose. I'll check my blood sugar every half hour after the rapid heart rate exercise, and I'll correct it with liquid glucose. 1 teaspoon of the liquid glucose that you can buy at any drugstore will raise me about 7 milligrams per deciliter. But I'm a small person, bigger person will have less of an increase. So that's what I have to do. I have to take the glucose to offset the drop, and it'll drop for 6 hours for me. Now, for some people who are not really following the method in the book, and maybe taking, for example, a little too much insulin for dinner, and then go down when they do aerobic exercise after dinner, that could be due to a little too much insulin. But I'm talking about the ideal situation, and I just told you how to handle it. Is there any benefit in taking hydrogen peroxide drops in 8 ounces of distilled water? Can you take too much? I don't know why anyone would want to do this. Hydrogen peroxide tastes terrible. It's very inappropriate for use on wounds because it destroys macrophages, which heal the wounds. It's good for cleaning surfaces. So if you're operating a lab that's handling blood and biologic materials, the hydrogen peroxide may be almost as good as Clorox for cleaning off surfaces. But I tend not to use it on humans. I guess if you put it on some skin before you are going to cut the skin, operate on it, so that not allowing it to touch the wound, but allowing it to dry before you did your surgery, there may be some value in it. Drinking hydrogen peroxide, if you drink enough of it, you're going to destroy bacteria in your gut and interfere with your microbiome. Will a few drops make a difference? I doubt it, but I certainly don't see any purpose in doing this. It makes absolutely no sense. The person doesn't say how many drops in 8 ounces of distilled water and why it should be distilled. If you're going to take something toxic like hydrogen peroxide, why on earth would you worry about the water being distilled? Okay. This reminds me of the many questions we get about people seeking magical solutions for all kinds of problems because they don't want to be bothered doing the difficult things that it might take to have a healthy life. I've read about inhalable insulin using meter dose inhalers. What concerns to you about using this form of insulin? Well, I have discussed this before. The major concern is the unpredictability. You don't know how much you're going to absorb from one dose to the next. Now, I do understand that some people with gastroparesis who will get a very high blood sugar out of the blue when their stomach finally empties after it's been loading up for a couple of days, some people have been using inhaled insulin to bring the blood sugar down because it works so fast. Now, I had been recommending intramuscular insulin for mild blood sugar increases, and for my rare patients with what I call end-stage gastroparesis, people who have nausea and vomiting from gastroparesis and go up maybe out of the blue to 300, 400, or 500 when several meals empty at once. I had them giving themselves intravenous injections of insulin, which works quite rapidly. But it's difficult to give yourself an intravenous shot. I've never had the guts to do it myself. I haven't had the need, but I certainly have tried as a matter of principle to be able to show other people, and I couldn't. I was chicken. So inhaling insulin would be a lot easier than injecting intravenously. The inhaled insulin, I understand, takes about an hour and a half to have most of its effect. Now, after it's had its first effect and it's unpredictable, you can then take a second dose when you see what's happened, if you still need some more insulin. So for these special situations, the inhaled insulin may be of value, but remember, it's unpredictable. You don't know how much it's going to lower you. And the amount it lowers you today might not be the amount it lowers you tomorrow, or the amount it lowers you at 1 o'clock today might not be the amount that it lowers you at 6 o'clock today, because the absorption is highly variable. What is your opinion of Invokana, just approved here in Canada? Invokana is in a class of drugs called SGL2 inhibitors. It lowers the renal threshold for glucose. We've discussed this before. It allows you to pee away glucose at a lower blood sugar level than is usually the case. Let's say that ordinarily you'd start spilling glucose in the urine at a blood sugar of 160. Well, with the Invokana, you might be starting to spill sugar in your urine at 110. So it gets rid of glucose from your blood by causing you to pee it in the urine. And just as if you had a blood sugar over 160 and were peeing glucose away in your urine, you're going to make more urine. You're going to get possibly dehydrated. So if you're using Invokana, you're going to have to drink a lot of fluid. I've used this on patients as a last resort, and many of them develop signs on their lab tests of dehydration, such as elevated hematocrit, low sodium, low chloride, elevated blood urea nitrogen. So we do see on routine testing effects of dehydration. I've seen a couple of people get urinary tract infections who are taking this. And since 25% of diabetics have CVID, an immune deficiency syndrome, those 25% are especially susceptible to infection. And of course, if you're taking Invokana and not keeping absolutely normal blood sugars, you're again increasing your risk of infection just from the elevated blood sugars. So there are problems associated with it. As I said, I use it as a last resort. For example, I may have a patient who absolutely refuses to take insulin, has elevated blood sugars. They're not astronomical, but they're high enough to cause potential problems over the long term. I might say, okay, we'll try you on Invokana because the metformin gave you diarrhea or something like that. There are several drugs similar to Invokana that have different brand names. For example, another question this month is about Jordiance, which is another brand of an SGL2 inhibitor. Same side effects, etc., same mode of action. What is your opinion on SSRIs and insulin resistance? SSRIs are antidepressants called selective serotonin reuptake inhibitors. The classic one many years ago was Prozac. Any difference you have seen amongst the SSRIs? Well, the main thing that I've seen is that some people overeat when they take SSRIs. Other people have an easier time controlling their overeating and carbohydrate addiction when they take SSRIs. So it depends on the individual. I believe that I read somewhere that taking SSRIs at the same time you're taking slow-release T3 for hypothyroidism might interfere with the absorption of the T3. I also should point out that any case of depression should be tested for serum-free T3 before given any medication, because a common cause of depression is low T3. So it's the obligation of every psychiatrist to check serum-free T3 before prescribing an antidepressant because the patient may not need it. Do you see any connection between diabetes patients who also have had psoriasis? Well, again, I say this in my book. I've said this before in my teleconferences. Virtually 100% of the diabetics I've seen have psoriasis. maybe once every 2 or 3 years, I'll encounter a diabetic who does not have psoriasis. I usually spot it by looking at their elbows and find that they have rough elbows. We may find they have rough knees. Those would be signs of mild psoriasis. We might find that they have missing lunulae or quarter moons on their fingernails, another sign of mild psoriasis. Or they have linear ridges or grooves on their nails, another sign of psoriasis. Itchy scalp, itchy ears, itchy nose, perianal itching. And in extreme cases, we've seen people who constantly itched all over their body. So most of the cases we see are very mild. I tried to get this published years ago. The brand new psoriasis journal at the time said, we're interested in psoriasis, we're not interested in diabetes. And the several diabetes journals that I submitted it to said, we're interested in diabetes, we're not interested in psoriasis. So I never got a chance to publish this observation. But if most of you who are listening are diabetic, just feel your elbows. The chances are pretty strong that you have rough elbows. Does occasional system cleansing render any benefit? I don't quite know what that means. It could mean taking laxatives or other things that destroy your microbiome, and I don't think that that would be a wise thing to do. I think it's asking for trouble. I have encountered people who've done this kind of thing and have had a host of minor problems. So I wouldn't get involved with this. Have had any of your clients experienced large itchy welts anywhere on their skin when using either Lantus or Levemir? No? Wait. Sometimes people have had welts when not injecting deeply enough. And some of the new insulins come in pens with very short disposable needles. And if the needle is too short and you don't give an injection deeply enough, you could get welts, and the welts can be itchy. These are called intradermal injections, and they do tend to itch. When you use these short needles, you have to go straight in. You have to hold the button down for at least 10 seconds, and then when you release it, wait another 10 seconds. And again, as I said, go straight in perpendicular to the skin. And even then, the needle may be too short. You may have to get longer needles. Some of the new syringes that are being marketed around the world have needles that are too short. For example, Becton Dickinson salesman, they're the biggest supplier of insulin syringes, gave me some samples of syringes with 6-millimeter needles. And I tried injecting insulin with them, and I had two problems. One, with most insulin vials, the needle wouldn't get through the thickness of the diaphragm on the vial to get any insulin. But when I did find vials that had insulin, I got welts from injecting too shallow. So this is a real problem that can be brought about by the lack of understanding of their own products by many of the manufacturers. The people who design the products aren't the people who use them. I recently had these blood tests: insulin, C-peptide, and hemoglobin A1C. The hemoglobin A1C, by the way, was 11.9, which is something like an average of around 340 milligrams per deciliter. Would these numbers represent type 1 or type 2 diabetes? Well, the C-peptide, which is a measure of the amount of insulin you're making, is, it really depends upon when you ate and what your blood sugar is at the time. Now, to have such a high average blood sugar of over 300 and a C-peptide of 0.67 tells me that this person is probably a type 1 diabetic. You don't see such high blood sugars in type 2s unless they're eating a lot of carbohydrates. So it could be that this is a type 2 who is eating a lot of carbohydrate and has therefore raised his blood sugar very high. That's a possibility too. So as I said before, without knowing the full history and what the patient is doing, you can't be sure of what the answer is. Okay. Is bone broth and kefir beneficial for diabetics? Again, looking for magic instead of doing things that require work. Bone broth is probably benign. Some people have said that it increases your availability of collagen, which may or may not be of value. Kefir, on the other hand, is a fermented milk product similar to yogurt, but usually with an unknown amount of carbohydrate, so it can probably have anywhere from small to large increases in blood sugar as a result of consuming it. I doubt that they're certainly not gonna undo your diabetes or be any kind of a cure or magical answer. Is sexual dysfunction related to diabetes type 2, and is it reversible? Well, this person should certainly read my book, Diabetes Solution, because we discuss it in a chapter entitled, more or less, What to Expect After You Control Your Blood Sugars. And what we find is that, well, let me backtrack. About 60 to 65% of male diabetics have erectile dysfunction. They can't get erections due to neuropathy. And the neuropathy is caused by high blood sugars. Now, neuropathies are usually the first things to come from high blood sugars, and also the first things to be cured after blood sugars are normalized. But the cure takes months. And what I've seen is a typical situation might go like this. A man says, I get an occasional erection, but it doesn't last long enough for me to have intercourse. So we normalize his blood sugar, and in 2 months, he says, I'm able to have intercourse again, but I had to be fast because my erection doesn't last terribly long. And then over the next 3 or 4 years, the erections last longer and longer and longer. That's a prototype situation. If a person has more severe erectile dysfunction, it might take many years to reverse it. So there's a whole spectrum, but uncontrolled diabetes is probably the one major cause of erectile dysfunction in the world. I might add that when I started in practice, the ADA was saying that erectile dysfunction was not likely to be caused by high blood sugars, rather it was a psychiatric condition, and that you should send these people to a psychiatrist. And yet I was doing RR studies and seeing that these people had very abnormal tests for autonomic neuropathy, and that they had other signs of neuropathy. And I don't think I found one case of erectile dysfunction due to a psychiatric ailment. Aside from the hemoglobin A1C test, is there any other test for estimating blood sugar? Well, the best test is to test your blood sugar with a good meter and use one of the meters that we recommend. There are two other tests of questionable value. There's the fructosamine test, fructosamine, and there's the glycated albumin test. These are other glycosylated proteins that have half-lives much shorter than the A1C, so they will reflect the average blood sugar over, let's say, the past 2 weeks. Where they are of value is in pregnancy, where the blood sugar status or the severity of the diabetes may be changing every week in the pregnant woman or every 2 weeks, and you want to track what's happening, or where the mother is supposedly testing her own blood sugar and reporting them to the physician, but the physician doesn't trust her, that she may be faking the data. He wants to double check, so he looks at the fructosamine or the glycated albumin. The trouble is that we don't have numbers that correlate glucosamine or glycated albumin with blood sugar. So we can't really say what the average blood sugar was. 72-year-old with an A1C of 5.6%, type 2 on metformin. Now right away I always ask, are you getting generic metformin or the real stuff, the glucophage? Because we find that the generic metformins don't work nearly as well as the glucophage. What are your thoughts on fasting 2 days a week and using your diet for 5 days a week to prevent being diagnosed with diabetes and to lose 25 pounds and get rid of belly fat? Well, if this person has an A1C of 5.6, which is an average blood sugar of 124, is already on a low carbohydrate diet and is already taking metformin, this person is probably a type 2 diabetic. If she is not on a low carb diet, she should read my book and should be on a low carb diet. And it's the low carb diet that's going to get rid of the fat. Fasting a couple of days a week has had questionable results. There are two sets of reports out there in the scientific literature. One that indicates that the people who fast tend to overeat to make up for it. And another study seems to show some possible small benefit. I doubt that it's going to be of any significant value. Well, that's it for tonight. Thanks for listening. Please visit Dr. Bernstein's Diabetes University on your search engine or at YouTube. You'll find many videos, about 100 or more. And visit us again on Wednesday March 30th for another teleseminar. Thank you. Okay.